directional region. So if I have a probe that's in this specific position on my screen, what is anterior, what's posterior, what's right and left, that's going to change a little bit when we go to the sagittal views to kind of understand those directional pieces. And then if I'm evaluating the aorta or the IVC from here, and I come from the coronal aspect, what changes? What kind of directions? So this ceases to be anterior, posterior, and now it becomes medial lateral. So the medial portion of the aorta, not the anterior portion of the aorta. So it kind of changes with our transducer position. Anatomic structures. So layering. So a lot of these things, when you guys learn in anatomy, you've learned about the pancreas, and you've learned about the gallbladder, and you've learned about, you know, whatever else. These all touch. All of these things touch. And so when you can't find something, you got to know where to go. So if I can't find my common bile duct, I'm going to go to my main portal vein. Can't find my main portal vein, it actually backtracks to the portal splenic confluence. Can't find my portal splenic confluence, I'm going to find the aorta because it lives anterior to the posterior to the end. Whatever, you got it. And so we're used to just things kind of existing in anatomy, and we're going to be seeing them directly related to each other. So how do I know when to find something? Find the other thing near it. And that becomes a really important tool as you guys move on. And then, of course, critiquing ultrasound images like, this one looks like crap, you know, that kind of thing. So body planes and positions, scan planes and transducer positions. This is not going to make too much sense to you today until you actually sit down and scan. So you can just like do a lot of head nodding today and be like, yeah, sure, whatever you say, Shea. And then when we start scanning, it will get a little bit better. Anatomic position. So we're really big on, okay, thumbs are out, feet are down. We're really big on talking about lateral and medial. We're about right and left, proximal distal, anterior, posterior. So we're going to use a lot of these. That will be kind of part of your new vocabulary. So the anatomic position. So the thumbs are always out. So the thumbs are actually the lateral aspect of the hands. And okay, so superior or cranial. They don't often use cranial, it's more of a vet med term. But superior is going to be above, right? Okay, this is hopefully not all that reviewable for you. What about inferior? Below. And then there's one called caudal. And caudal, you know, if you're talking about your leg, you wouldn't have caudal. Caudal means close to the tail. Not a term that we use a ton of, but something you may run into out in the real world. And then lateral is going to be, of course, to the outside. Medial is going to be to the inside. When I'm scanning over here, on one side of midline, you know, on the right side, so I'm going to have then the left lateral and left, I'm sorry, right lateral, right medial, but when you're scanning midline, you can just call it right and left. So it depends on whether we're at that kind of, that sagittal section of the body. Anterior or ventral, so it's going to be to the front, and then posterior dorsal. These are going to be biggies for us. So every image we take on this anterior portion of the abdomen, the top of my image is going to be anterior, the bottom is going to be posterior. And regardless of whether I'm in sag or transverse, that doesn't change. So anterior, posterior become really big kind of talking points to us. To you, now to you. Okay, ipsilateral or contralateral. So whether we're on the same side, so the thumb ipsilateral to the pinky, or the thumb ipsilateral to this pinky, or contralateral. So are we talking about the same side or different sides? Proximal is going to be away from the area of reference. When we get into like the common bile duct, the proximal portion is where it comes out of the liver. The distal portion is where it meets up with the pancreatic head. Then we also have proximal distal, like with an extremity. So proximal and distal are really important. And then superficial and deep, we're going to have a little bit more of this next quarter when we do small parts. But if I have a breast mass, is it superficial or is it near the chest wall? It's very deep. Okay, so shout it out, folks. Where is the thumb in relation to the pinky?
Lateral.
Yes, lateral. Yes, Jay. Okay, so where is the liver in relation to the uterus?
Superior.
Superior, you got it. Where is the right kidney in relation to the sternum?
Inferior.
And posterior. And posterior, you got it. And then where is the armpit in relation to the elbow? Proximal. Oh man, you guys are nailing this. Okay, where is the kneecap in relation to the heel?
Distal.
You can say proximal if you wanted. You can say superior.
Anterior.
And you're going to say, yep, anterior. You got it. And then where is the ovary in relation to the bladder?
Lateral.
Lateral. Lateral. And it can be kind of superior and it kind of be a little minds of their own. They wander around. Okay. So some of the positions that we're going to run into out in the real world, our most common is going to be supine. That's when we're scanning our patients and they're laying on their backs. We also do a lot of LLD, RLD kind of rolling. We always look at the gallbladder in two planes and to see if there's any kind of little stones that roll out of it. So sometimes we actually have to write on our images which position our patient's in. Other times, we don't care. Upright, we don't have to do this very often, but you might get patients who are wheelchair bound, or they have a stuck gallstone and you want to see if you can get that gallstone unstuck, or you want to see that pancreas, you want it to kind of fall down a little bit, so maybe it's upright. And then there's Trendelenburg, and that's where the legs are above the head. This happens oftentimes, at least in my world, with pregnant women where I'm trying to get that baby's head away from the cervix. So I'm just gonna, make her go upside down so that baby kind of travel down and give me a little bit of a window to see through. Okay, so here's our basic scan planes. So we're gonna mostly work in this sagittal plane, so cutting the body down this direction, transverse, and then there's this mind-boggling coronal. And coronals where we're kind of slicing through this way. We'll get there. We won't worry about it today, but coronal, it becomes important when we're like talking about baby brains or we're doing a transvaginal exam because we're in the coronal plane. So don't be scared of the coronal plane just yet, but for the most part, we're going to be working sagittal and transverse. Okay, so when we, let's do one of these. When we scan a patient on the anterior aspect of their abdomen, and I'm in a sagittal plane, so here's our little dude. Look at me, I'm getting scanned. Yay, this is fun. So here's our little probe. You have what's called a home. Here's the card. That's the card, the cord. So we always want our notch or our home to be between noon and 9 o'clock. So noon for our sagittal, you can kind of fudge it a little bit, and then transverse is going to be at 9 o'clock. You can kind of fudge it a little bit, but those are our basic scan planes. And we'll go over this extensively, so just, bear with me here. So if I'm in sagittal, so I'm scanning my patient this way, my little home is up here. This becomes anterior, this becomes posterior, this becomes superior, this becomes inferior. So kind of our basics for our sagittal plane. Scanning on the anterior abdomen. Next up, we're going to switch. Oh, Shea's 3D is really horrifying. Okay, all right, I kind of pulled that one off, maybe. So we're going to switch to transverse. So we're cutting our patient in a transverse plane. And in that case, we're still going to have our anterior and our posterior. And then instead of superior inferior, like we had here, now we have right left. And this is going to be the right side, this is going to be the left side. Or if I'm just on one side, it would be right lateral, right medial, but we're just pretend we're just looking at that midline structure right now. Making sense so far?
Mm-hmm.
Okay, perfect. And then when we do that mid-sagittal, we're going to look at that area to measure the left liver lobe, and then we have what's called the mid-clavicular line, and that's between like the nipple and the iliac, and we use that to measure the right liver lobe. So we've got a couple landmarks on the body in the sagittal or transverse planes that we use to reference things. Okay, so on the body, it's going to be right to left, and again, unless I'm on one side or the other, then it's going to become medial lateral, but if I'm midline, then it's just going to be right to left. And if we look at how our probe is here, so we have the anterior, so if I take a slice of myself out, this is going to be anterior posterior, so whether I'm in sag or transverse, that AP doesn't change. So you'll notice both of these have anterior posterior. We're just changing from sag to transverse. Making sense?
Mm-hmm.
Okay, so coronal, let's just ignore this one. Reminds me blowing my ear about it. So here are the basic regions of the abdomen. As sonographers, we typically work in right upper quadrant, left upper quadrant, right lower, left lower. Although you can actually break this up into four. So the hypochondriac, lumbar, iliac, and then I don't know what these are. They're in here somewhere. But we typically use our right upper quadrant, right lower quadrant, left upper, left lower. And here's all these ones. So in our four quadrants, the things that are bolded are the things that we as sonographers are going to evaluate in that particular quadrant. So right liver lobe, gallbladder, pank head, I should say, and then right kidney are all going to be in that right upper quadrant. Right lower quadrant, appies, so right ovary, fallopian tubes, ureters, if there's a male spermatic cord. So these are the kind of things that we want to focus on within each of those areas. And the left is not very exciting. So left liver lobe, spleen, pigtail, body, and then left kidney is kind of the big ones. And then left lower quadrant is fallopian tubes, reproductive organs, ureters. It's kind of an empty neighborhood. It's not very, you go to OP scanning, like, I can't see anything. I'm like, there's nothing to see there. There is nothing to see. Okay, so these are the 9 regions, which I will never ask you, but it might be something to put into your study guide or think about, just have in the back of your memory, but I will never ask you about it. And then we also have, so we have right upper quadrant exams are typically going to be a liver and a biliary evaluation. If we have epigastric pain, we're going to be looking at pancreas and biliary. Flank pain is typically going to be renals, ureters, appies on the right. Pelvic adnexal pain, so that's going to be bladders, ovaries, uterus, OB, prostate stuff. Lumbar is typically confined to renals, ureter, and prostate. So those are kind of the areas that they'll say, oh, we have pelvic pain, lumbar pain, epigastric pain. So those are the things we're going to kind of hone in on when we do those exams. Okay, so clinical reference points. So we have that midline, which is where? The easy one. It's in the middle, right? Right. Yeah, so we have midlines. We use that as a basis for comparison on a lot of things. And then we have that midclavicular line. So that's going to be between the nipple and the right iliac, or left, or whatever side. And that's where we're going to measure that right liver lobe. There isn't much going on the left side over there. We also use intercostal. You heard the second year speaking about that. That's where we're actually going through the rib cage. So we're going to position our probe kind of between those 2 ribs and try to sneak around and look around in there. And we have what's called subcostal. So subcostal is below the costal margin. So that's going to be a big window for you guys too, for livers, kidneys, things like that. And then we have substernal or subxiphoid, and that's going to be more epigastric, so our great vessels when we scan next week, or if I'm looking at pancreas, that's going to be kind of below that xiphoid. Any questions so far? Are you whelmed? Underwhelmed? Overwhelmed? Just whelmed? Okay, so let me grab one of these bad boys. And this will make a little bit more sense when we're in the lab this week and actually can touch the transducer. But every transducer has what we call a home or a notch on it. And that's the part that's going to stay between noon and 9. And you can fudge a little bit, but for the most part, it's going to be either at 9 o'clock. Oops, the other 9 o'clock. No, the other one. 9 o'clock or noon for sagittals. So it's kind of our neighborhood that we sneak around in. There are always going to be exceptions to the rule, but that's kind of our basics. So if I'm scanning coronally, right? So still it's going to be kind of pointed to my patient. So the right side of my patient's always going to be on the left side of my screen. So it gets a little bit kooky. So when you guys scan this week, our notch is going to be pointed at 9. And so anything on that side of the screen is going to be the right side of your patient. And it took me a long time to kind of figure out how that worked, but it just works. It's amazing. Good to go on that? Any questions so far? And once you scan, it will make more sense. And it's not like, ooh, theoretical, not still. It'll make a lot more sense for you actually to scan out the patient. Yeah. Oh, look, more on this as well. Almost like I wrote this PowerPoint. Okay, so grayscale. This is more of our physics stuff. So these waves go into our patient's bodies, and depending on what kind of frequency, so lower frequencies penetrate a lot deeper, so they can go all the way down to the liver. And then those higher frequencies don't penetrate, but have better resolution. So they can see things better. The wavelengths are much smaller. So we'll talk about that more on physics, but that's kind of basics. We put sound in the body, it reflects back, and the volume that it reflects back at, so the amplitude that it reflects back at, gives us an indication of the tissue type. So something that's flat or bone, it's going to, a lot of my beam's going to bounce back, so it's going to be very white. Anything that's fluid, so a cyst or a bladder or a gallbladder, none of my sound has anything to reflect off of, so it goes all the way through it. So that's why those are black. So there's no amplitude being returned. And everything that's kind of gray is kind of in the middle of all of that. So it's kind of the basics on how we work in our world. Okay. All right. Here's your new language. You're starting a new language today. So hyperechoic. So that's when I have more echoes returning back from a particular area. So it's going to be like a lighter shade of gray. Then I have hypoechoic, and this is all relative to like its neighborhood. So I have a hyperechoic mass in the liver. So it has a brighter area than the rest of the liver. Or we have a hypoechoic mass, so it's going to be a darker shade of gray than the rest of the liver. So we're always referencing something. You can't just say, hey, that's hypoechoic. To what? To the liver, to the kidney, you know, what are we dealing with? Anechoic, that's what I was talking about when like our, when we have that fluid, none of our beam returns back, so it's gonna be black, so it's gonna be absence of beam. Sometimes we have other things that will cause our beam to be black. So if I'm scanning through and my patient's rib is there, and I have these two big shadows, it's not because it's a fluid collection, it's because my beam's not getting through. So that would be a shadowing area, not an anechoic area, because anechoic indicates that there's fluid, or it's an organ or a structure. Next up, we have homogeneous and heterogeneous or inhomogeneous. So this is just, we have uniform composition through this liver. Is it looking very nice? Or is this person that have a history of hepatitis and it's very kind of mottled looking and it doesn't match, nothing matches. So homogeneous or inhomogeneous describes the uniformity to that tissue type. Okay, so typically, again, as you get scanning, this will make a little more sense. White things are going to be either like calcified structures, so things that are bones, gallstones, I don't know, renal stones, or it's going to be a flat surface and it's so flat that it reflects a lot of our beam back. And our machine loves flat surfaces to have our beams back. So sometimes like that diaphragm we saw earlier, it's not made of calcified structures, it's just reflecting a lot of our beam back. Then we have that kind of medium gray. So that's kind of what most everybody's going to fall into, the kidneys, the liver, everything like that. And then low level gray, so it's going to be a little bit darker. So that's going to be maybe the cortex of the kidney where it's a little bit darker than the pelvis around it. And then black is fluid, so there's really no reflection back there. We don't get any of our beam back. Okay, so in this case, the liver, this guy, is hyperechoic to the right kidney cortex. So we have hypoechoic, hyper. So we're making a comparison between the two. You couldn't just say, oh, look at my, hyperechoic thing. Like, compared to what? Or what are you comparing it to? Hyperechoic to the liver, hyperechoic to the kidney. All right, this is hepatic veins. We'll get to scan some of these. So here's that diaphragm, that big flat sheet, liver right in here. And we have what we call a portal vein right in here. They have echogenic walls, amazing. And then we have, this is actually the IVC cross-section. It would be coming out here, going straight into the heart, or coming out towards our patient's feet. And this is a hepatic vein right in here. So it's anechoic, it's fluid, it's blood. So there's no returning echoes. Okay, so here we have a gallstone. So here's our normal gallbladder. He's got a nice flat wall, so he's going to reflect a bit of our beam back. He's anechoic inside, it's filled with bile, which is fluid, right? So there's no reflecting beams back to us. And then this guy has a gallstone. And gallstones are calcified, so you can see how much reflection we have from that gallstone. And then one thing that stones really like to do is they'll have a shadow, what we call posterior shadow. And what's happening there is my beam is going in, it's reflecting off that gallstone, and then it's coming back to the transducer, and there's nothing continuing to go through that stone. So it's basically like a shadow, like our flashlight kind of shadow. Stand in the way, there's nothing going on. Okay, so this is kind of diffusely inhomogeneous, and I know you don't have much of an appreciation for this quite yet, but if we look at this liver, you can kind of see how uniform it looks. It's kind of all one echo texture. And if you look at this guy, kind of lumpy looking, it's kind of not correct. You'll develop isometric, I promise. And then here's focally inhomogeneous. So we have liver masses. These are focal liver masses. And we'll work with a lot of this terminology. You'll have overlap in all your classes. I don't expect you to go home today and immediately know what focally inhomogeneous is right off the top of your head. But we'll get working with the terminology a little bit. Okay, so now we talked about with that gallstone shadowing. So I have that stone is reflecting a lot of my beam back. My beam is not able to make it through that stone, and so I end up with a shadow, a posterior shadow. Then we have some other things that they do. So in this case, maybe I'm going through the gallbladder, and my beam's going through, and instead of reflecting off anything in the gallbladder, because it's a cystic structure, it's anechoic, there's no returning echoes, posterior to that gallbladder is going to be a little bit brighter than the area around it. It's preserving that beam as it's moving through that area. So we can have one end of it where it's getting shadowed and our beam's reflecting all the way back, or we have the other end of it where our beam isn't reflecting back, and so it's even brighter. It's kind of the increased amplitude is kind of preserved because there's nothing there to reflect it back. So a little bit of physics in there, and everything there, right? Okay, so as far as shadowing goes, there's multiple types of shadowing. So we can have like that calcinet stone had a really dark black shadow, right? Let's go back and check it out. So see how dark this is? Ooh, we're not able to see behind it. And then other things that shadow is our bowel gas. And we're not very good at ultrasound at looking at bowel. We're kind of bad at it. Appies are one thing, but we're not very good at bowel. But that gas within the bowel will reflect a lot of our beanbag, and we'll have like a diffuse shadowing, kind of a gray shadow. So it's not absolutely black, it's not anechoic, but it's got some kind of gray haziness to it. And the more you guys scan, the more this will make sense. And then we have what's called edge shadowing. So edge shadowing occurs when we have a rounded structure. And who knows what refraction is? I do. Oh, really? All of you know? Oh, I'm so proud. Okay. So refraction is the bending of our sound beam. You'll see this. I am notorious for losing my pen and kicking this thing. Okay, so what will happen is, our sound's coming in here, sound's coming in here, sound's coming in here, and on these curved structures it will be redirected, and that leaves, then that leaves an absence of sound in these particular areas. So we call it edge artifact. So that's a thing. You'll learn more about it. But those are kind of our edge shadowing. So we gas shadow, calcified structure shadow, and then edge shadow. So here's that shadowing right in here. This is rib and lung. So we've got some ribs here, so it's kind of a darker shadow. We've got some lung in here, so it's the pleural lining, so it's very flat, reflecting a lot of our beanbag. We just don't have much going on in this neighborhood. There just isn't much to see. We're shadowed out. And then here's a little bit of edge artifact. So here's that gallbladder. We've got that rounded side to it, and so the beam is being kind of redirected this direction through refraction, and then we get kind of absence of our beam in that area. More on that with physics. I know you can't wait. Okay. This is a little tricky. So we use the word complex in two different ways. So if I have a gallstone, or if I have a pathology and it's totally anechoic, we can call that simple. It's a simple cystic structure. There's no debris in it, there's no hemorrhagic products in it, it's just absolutely anechoically black. So that's going to be simple. But then I can have complex fluid. So that means there's debris in there to some degree. Whether it's little calcifications within the gallstone, or whether it's a hemorrhagic ovarian cyst, but there's some complexity to it. There might be what we call mural nodules, so maybe there's some actual like a growth. Are you sneaking out of here? Okay, I'll talk to you soon. Like an actual like soft tissue growth in there. So that's called complex fluid. Now, this is where your minds will get boggled. Everybody screws this up, don't feel bad. Complex structures, those are different. So complex fluid is a fluid-filled structure with debris. A complex structure means it has soft tissue and fluid components. So some of these really hairy, scary looking thyroid things, they have a soft tissue component. You might put what we call color on there, and it glows because it has vascularity. And then the fluid itself is either complex or anechoic. So you can have a complex structure with complex fluid, but they're separate things. I know, right? I know. Why would make this easy? Why would they do that? Whatever. And then solid is having only tissue components. Vascular is where we put our color Doppler on, and we can kind of see it'll glow like little kind of Christmas lights, and then we can actually evaluate the velocities involved in that. But some it's vascular. And when we talk in pathology, there's ways that we can describe vascularity. Is it diffuse? Is it focal? Is it peripheral vascularity? So there's some other terminology that's going to go on with our vascularity. Well circumscribed means having smooth borders. Irregular borders, maybe we have irregular shape, there's lobulations to them. It might be that it's really hard to determine exactly where the pathology tissue starts and the other normal tissue ends. So it might be just difficult to distinguish those borders on. We can also have what's called septated or loculated. So we might have a cyst with some kind of echogenic stranding in it, and they're like little septations. Typically, the thinner is better, because you get some really thick ones with some of these bigger liver masses, and you're like, that is not helping. And then hemorrhagic means having blood components. So a lot of these ovarian cysts that we run into have a complexity, and they're hemorrhagic. when we are talking about transducers, that frequency is gonna matter. And so the lower the frequency, the more penetration you're gonna get. The higher the frequency, the more superficial but better resolution. And we'll talk about more about that in physics. But basically, what depth do I want? Am I doing something deep like the liver or the thyroid? And then how much detail? So those higher frequencies have really tiny little wavelengths. And so when they, my pen, I've got two of them here. Stack them up. So when we talk about resolution, our longer frequencies, long, low frequencies, we're not able to distinguish two structures as separate very well. This is our high frequency. So these are more like, so then you can just distinguish two structures as separate well. And we'll talk about that in physics. But so how much detail do I want? Do I need a lot of detail? Am I doing something very superficial I need a lot of detail on, or not? And then of course, what type of exam we're doing? We're doing an internal exam, we're doing an external exam. So I'm not gonna take one of those giant probes and try to shove in my patient to the transvaginal, right? So instead we have a transvaginal probe for that. It's more appropriate than a giant transducer in your hoo-ha parts. Okay, so that's your home, that's the right part of the screen. I think I talked to you about that. So on the machines, you're gonna have that, and there's a button that will switch it around, so don't touch that button. You can touch all the rest of the buttons, just don't touch that one, and then you'll just end up absolutely confused. So we'll make that one work too. Okay, so home is gonna be the top left of our screen. And we kind of talked about our sag versus transverse. And so here's my ultrasound screen. Here's my little image right here. Here's my little home button. And that corresponds to the notch on my transducer. Remember how if it was up here, I have a superior, inferior. If I'm in transverse, it's gonna be right and left, depending on. And then the AP will stay the same. So if you're ever like, I don't know which way this probe is, pet the portion on your probe with the notch on it, and it should be on this side of the screen. It should be on the patient's right, real people, normal people left. And I do not know my right and left very well, so this is the way I remember. So my patient's laying right here, so the side closest to me is my patient is right here. So that's how I remember my patient is right here. And we'll talk about that with lab too, because you'll be like, I don't know what I'm doing. And okay, so yeah, if you can touch that little portion, and it should go on the left side. So here's a transverse gallbladder, a little gallstone in it. So we've got anatomic, echogenic, liver over here. And here's a transverse urinary bladder, so we're transverse on the patient's body. So here's our little home. We've got right side here, left side here, anterior and posterior. And here's remember we talked about that enhancement, so that beam is actually preserved and gets a little bit brighter as it goes through the structure. So in this case, we have kidney cortex here. And see, we have this little strip of bright. So our beam is going in here, and what we call attenuating is kind of, getting lower and lower volume as it goes. But in here, the volume went up, so the amplitude increased. And so this little cystic area doesn't have any beam bouncing back, so it does what's called enhancing. So it's kind of the opposite of shadowing. There's a very nice anechoic renal cyst. So a little bit of a kind of odd shape to it, but here's our little renal cyst. And newsflash, I don't care about cysts. Isn't that stupid? I know, when I was a student, I used to be like, let me document every single one of these things. And like, yeah, okay, patient's got cysts, big deal. I'm like, that's it, what are we doing? Oh, nothing, I'll just come back later. Or it's like, oh, okay. And then I have a really good story. So I was doing this guy, and I thought he had a mesenteric cyst. It was like a perfectly round cystic structure right in the mesentery. I'm like, I've never seen one of these. Life is amazing. Like confetti should be falling from the ceiling right now. And so and he had a couple other things going on. So I go to read the radiologist report, and he's like, penis pump reservoir, inappropriate location. And I'm like, wah, wah, wah. I thought it was like a mesenteric cyst. It was like a penis pump. So don't be ashamed. Okay, so this is kind of solid renal mass. So this is a kind of a crappy image. We've got the cortex of the kidney right in here, and then eventually your eyes will kind of develop these shapes and things, but we've got this nice central mass right in the pelvis of the kidney. So this is an ovarian cyst. So there's two types of complex, right? There's complex when the fluid has debris in it, and then there's complex when you have a mass with soft tissue and fluid components. So this is a complex. So we've got double. So we've got some debris in here. We kind of see in the anechoic components. We've got a little bit of debris, so not totally anechoic, so complex fluid. And in this entire structure here is, we've got soft tissue and fluid. So we've got a complex complex mass with complex cystic components. So the two types of complex, which is probably complex to hear about. Okay, here's another one. This is a hemorrhage. What is going on with my screen? Okay, well, so this is a hemorrhagic ovarian cyst, and you can see that instead of being completely anechoic, it has this kind of spider webbing look to it, and that's from a cyst that has hemorrhagic or blood components. So the cyst has bled into itself, and now it's kind of solidified into a blood clot. And hypoechoic liver lesions. So we've got, here's our nice normal liver. Here we've got this big hypoechoic part right in here, another hypoechoic part right in here. So we're comparing, and one right here. So we're comparing its hypoechoic to the liver. Okay. Breather, want to take a breather? Up to you.
No, we're okay.
Democracy.
We're okay.
Want to take a few minutes? Good to go? Okay, green light. There's only 99 slides. Okay. All right, so this quarter we're going to do basically an overview of the abdomen. We're going to start that with our major vessels, liver, gallbladder, biliary, moving into pancreas, spleen, kidneys, and then some pelvic anatomy. This class goes a little bit more into the anatomy because you only have it once. So we're going to, next quarter we're going to learn about scrotums and things like that, but we're going to get some of the basics out of the way this quarter because 105 only lasts one quarter. Oh, that's the other thing. I talk really fast, so if you guys want to record the lectures, go for it. Or if you need to just say, slow down, lady, but I'm very chatty Cathy, so let me know if it makes you crazy. Okay, so in the abdomen itself, we have the superior border, which is the diaphragm, and then we've got inferior borders of pelvis, anterior is going to be those abdominal wall muscles, and then posterior border is going to be those vertebral bodies, the ribs, the iliac fossa. So that's kind of what we're surrounded, this abdomen is surrounded by. And now we're on to the great vessels. Okay, so aorta, basically main line of the body. So this is coming out of the heart. The blood is coming back, well, it goes through the pulmonary circulation, goes to the heart, and now it's being ready to be distributed systemically throughout the whole thing. So we start with our arteries. So biggest artery in the body is going to be the aorta. Then we get to those arterioles. Is this sounding any familiar? Then we get capillary beds, and then we get venules, then back to veins, and then we have the other big guy who goes back in the heart, who's going to be the IVC, inferior vena cava. We just call him IVC. If I were to talk to my radiologist, like, my inferior vena cava is really amazing today, he'd be like, what are you talking about?
Mm-hmm.
Oh, IVC? Yes, there you go. Okay. So we have a tendency to think that veins are always deoxygenated. However, it's more about direction. Veins go back to the heart, and then arteries go away from the heart. So pulmonary arteries that are leaving the heart, they are not oxygenated. When they come back as veins from the pulmonary, lung business, then they do have oxygen, and they're still considered a vein because they're going back to the heart. So it's a little bit goofy. So I think in anatomy we kind of tend to think, and maybe they dumb it down for us, like, oh, well, arteries always have oxygen. Veins do not. It's like, not really. So pulmonary kind of screws that up. And then when we start looking at arteries and veins on our color Doppler, it's going to be red and blue. And you're going to think, oh, it's red, it must be an artery. Nope, it's only directional. Red's going towards the transducer, blue's going away. So if I have a vein that's pumping this direction, I can change it so it's, oh, now it's going towards the transducer. I come down here and make it a different color. Oh, it's blue, it's going away from the transducer. So we can manipulate that. So no more red and blue. So you have to pull that out of your little lines. Okay, so proximal versus distal. Okay, so arteries is going to be from our heart to our iliac. So the proximal portion is going to be close to the heart. The distal portion is going to be out in the tissues. What we talk about with aorta is we talk about our proximal aorta. So there's the aorta that goes all the way up through the thorax, and we have the what it would be descending arch and then ascending aorta, candy cane looking thing. And we deal with it after it's left and gone through the diaphragm at the level of the thorax. And that's what we call our proximal aorta. So that's where we're kind of starting out. That's the area we're going to look at first. And then veins, Okay, we're collecting blood, so it goes from the iliacs back to the heart, to the right atrium of the heart. We're gonna actually be able to see the right atrium of the heart, kind of that valve opening, I don't remember the name of the valve, opening and closing as that IVC is perfusing that right side of the heart. So this is gonna screw you up. Proximal for veins, because they're coming towards the heart, is gonna be out in the tissues, and distal is actually gonna be where it plugs into the right atrium. Because it's confusing, we just call it the superior portion of the IVC. We don't worry about talking about proximal or distal for the IVC, it's kind of boring. Okay, we talked about this a little bit. Veins originate in the capillary bed, so they go capillaries to venules, then to veins, then to the IVC, and eventually ends up in the right side of the heart. Left heart, so we're going to have that left heart contract, and it's going to eject blood into the aorta, then it goes to the arteries, arterioles, and then finally to the capillaries. So that kind of exchange at the capillaries is where something becomes going from an artery to going to a vein. So right in that capillary bed. Okay, so wall thickness. Arteries have very thick muscular walls, and when we scan next week, when we scan this week, but when you guys see it, you'll see they kind of pulsate. And they have that heart that's kind of push. It has a real high pressure, high velocity. Whereas veins are the lazy guys. Like, we gotta go back to the heart. So they're very low velocity, but they are what we call high capacitance. So like if I'm running, my veins will kind of overfill. My body will allow that vein to overfill slightly, whereas arteries stay pretty much the standard size. And they're so very low velocity, very low pressure. And so they also have, the valves you guys learned about, like calf muscle pump and all that. So valves are seen in veins, not in arteries. Oh, look amazing. Oh yeah, it's a diagram. Okay, so this is kind of where our exchange occurs. So you can see that, well, this is a, I don't know, good representation. You can see that they have kind of the same looking media, but the thickness of the musculature is going to be much thicker in the aorta because it's trying to accommodate for that really high velocity that's going through it. Okay, we were there, no one cares. Okay, so the pump. So the right side, so we get deoxygenated blood from the IVC. It's going to push that deoxygenated blood to the lungs through the pulmonary arteries. We're going to oxygenate. And another thing to note is veins will collapse. So if I'm looking at the aorta and IVC, I'm like, which one's which? I can squish with my transducer, and veins are so low pressure, they just squish away. Whereas that aorta's like, what are you doing? Why are you pushing on me? I'm staying the same size. So when in doubt, just push with your transducer, and the low pressure of the veins will allow them to collapse. So then we get oxygenated blood from the lungs, pulmonary veins, and then we're going to push that out through the aorta, and we're going to then perfuse the body forever. Very high velocities, and we'll get into that with physics as well. The high pressure, high velocity for arteries, low pressure, low velocity for veins. Ooh, amazing. Ooh, a diagram. You've probably seen 1,000 times in the last year when you were doing ANP. Here's what it looks like on ultrasound. So we're sagittal on my patient. So my notch is going to be at noon. So this is going to be the superior portion of my patient, head this way. This is going to be the inferior portion of my patient, so feet this way. And then here's my aorta right in here. And he's adjacent to the liver, and then this is what we call you guys remember the EG junction is? Esophageogastric junction. No? Well, that's him. So. Alright, and here's the IVC. So you can see the IVC, not quite a stick straight, and again, we'll learn this in like 3 other classes, so you don't have to rocket science it, whatever. Then we have that hepatic vein coming in, and then this is actually going into the right atrium right in here. So IVC to right atrium. Here's our diaphragm, so this is where it becomes kind of more in the thorax portion, and into the heart. Don't worry, this makes sense. Okay. Bear with me. And then when we're in transverse, so now I've got a transverse on my patient, and I've got on the left side, it's going to be that aorta, and it's going to be like the pulsing guy. On the right side, it's going to be the IVC. So if I were to squish my patient down, this would actually coapt. It would actually close itself, and the aorta is just like, ow, what are you doing? Why are you doing that to me? Okay. I don't care about this so much. It's important to know. I'm not going to ask you it on the test. I may have you like draw like for a homework, but I'm not going to ask you specifically this stuff. So you put that one away. divisions of the aorta. So proximal area is anything from that very top of that thorax down to where the celiac trunk is. And again, we'll scan it and you'll get to see the landmarks. It will make much more sense. And then the mid area is just below the SMA, superior mesenteric artery. And then that is going to include the renals. But sometimes we don't see the renals very well in some of our patients. So just like, yeah, sure, they're probably in there somewhere. Let's call this the mid. And then the distal area is that inferior mesenteric artery, and it's all the way down to the bifurcation of the iliacs. And when in doubt, that distal aorta looks like an old lady finger. So if you could see like this witch's finger, then you know you're at the distal portion. So if you're like, how distal am I? Just go to the very bottom and then just work your way back up. Okay. Okay, celiac trunk. Okay, you're gonna do this in brains class. No one cares. No one cares. If you do, no one cares. So this is showing my aorta. This is the celiac axis coming off, celiac trunk, and then this is that superior mesenteric artery. And so they're kind of two little extensions off that aorta. There are a couple big things I want you to take away from this lecture, and we'll talk about them in a second. Well, that's called the seagull sign. So we're in transverse, and we have this kind of looks like a little seagull. So that splenic and that left gastric, and then the common hepatic proper are all splitting and going different directions. So it makes like a little seagull. So here is our little seagull sign. Right in here, aorta. Not seeing too much of the IVC river here. Okay, so we put that color flow on there. So we've got aorta here, and here's that seagull sign. We're ignoring this guy. You don't have to know about him yet because he's, you know, there's a few down the road. And then we have that IVC. Okay, SMA. Okay, so this is a really important piece of anatomy. So where I have, so here's our aorta, and we've got that SMA coming off. So this is superior, inferior, anterior, posterior. So if you can imagine on this side, we're going to have the IVC. On the far side is the aorta. So this is the aorta. The renal vein, the left renal vein, sneaks between these two. So if I was an IVC and I'm reaching my arm over here, it sneaks between those two. So between the SMA and the aorta is the left renal vein. Shea, why do you care about that? Well, let me tell you all about it. So there's a thing that can happen with patients, and it's called Nutcracker Syndrome. And so our SMA, normal every day, we haven't eaten yet, kind of lower velocity, what we call resistance. It's like, no, I don't need blood cells. Take the blood and put it somewhere else. And then once we eat, then that vessel will plump up, and it can actually compact and contract on top of the left renal vein, and then the blood can't drain from the left renal vein, so then you get like a buildup of blood flow back into the left kidney. So it's called Nutcracker Syndrome. We'll talk about it some more. But the important piece of anatomy right now is that our left renal vein is between the anterior SMA and the posterior aorta. Why? Who knows? Yeah.
Why is it called Nutcracker? Is the kidney the nut?
Well, I think because I think it's just like
because it's cracking
the SMA. Yeah.
Oh, okay.
Should be like a kidney exploder. Or
Yeah.
yeah.
Sorry, could you repeat that? That last
Yes.
phrase that you said.
So, I know. Okay, so, Tommy, could you please be my IVC and I will be your aorta? So, Tommy's gonna put his little arms out. Ooh, look at you. So I have an aorta and I have an SMA right here. So then, that SMA, when I eat, it's gonna plump up and I go whoop, and I block that renal vein. And now the blood can't get back from the renal vein. Does that make sense? Okay. You're a great IVC.
So left renal vein is LRV, right?
Yes, left renal vein.
But it's really a rare condition, is it true?
Correct, it's rare, but it can happen, yeah.
Mm-hmm.
And so we usually have what's called postprandial pain. Postprandial means after eating, so they'll get pain after eating.
Uh-huh.
How you guys feeling? Okay, so this is one of the big takeaways right here, this piece of anatomy. And then it interacts a lot with the pancreatic anatomy, which we'll talk about that later. So here we go. So here is, we're in cross section, so here's our aorta right here. Here's that SMA, so that elephant trunk, and we cut it in half, now we're just seeing two little circles of it. And here's Tommy, and here's Tommy's arm extending to that left, this is the left kidney right in here, this is liver, spine. And so you can see that it goes between the two. So if this SMA plumps up after eating, it can compress that renal vein, which is never good. I don't know what I'm doing. Oh, celiac access to the SMA. So we've got celiac right in here. SMA, here's our aorta, so superior, inferior, anterior, posterior, liver in this neighborhood. And then we'll worry about him, the portal chronic confidence, we'll worry about him down the road. Okay, got it, Shea. How many pictures of aorta? Okay, so here's that again in the ultrasound. So we've got aorta right in here. Here's that SMA, so we're cutting that aorta and SMA and we're doing transverse on it. Here's my IBC and Tommy's little arm sweeping between the two. So anterior is going to be the SMA. Posterior to that is going to be your left renal vein, and then further posterior is going to be your aorta. Yeah, we need to know a ton of anatomy. So again, like say I couldn't find Tommy's renal vein, so now I'm going to follow that. I'm going to try to find the SMA. I'm going to try to find the aorta. I'm going to try to follow it from the IBC. So we have to kind of look at everything. As not just like here's a pancreas, here's a gallbladder, but they interact. Everything interacts. Okay, renal arteries. So the left is slightly superior to the right. Why do you think that is?
The liver.
The liver, that's right. So the liver kind of causes that right kidney to be a little bit more inferior in our bodies. And then why do you think on the arteries, why is the right renal artery longer than the other one? So aorta's on this side, IBC's on this side. It's to reach across the body, right? It's to go all the way. So he's on the left side, he's trying to perfuse that right kidney. Oh, right kidney, here, woo. So it's going to be a little bit longer than that left side. Now this is also another one. Would you please do my IBC again? Okay, so we already know that I have this, elephant thing. So anterior to the aorta, so anterior to me, is going to be the renal vein, right? We talked about that a second ago. Now on this side, I get to give Tommy a hug, and running posterior to the IBC, the only vessel running posterior to the IBC is going to be the right
renal
artery. Yep, you got it. Because they give each other hugs. But yeah, so that right renal vein artery is the only thing that runs posterior to the IBC. That's it. Okay, renal artery. So here's kind of, this one has a duplicated venous system, arterial system. It's got like two renal arteries going into it. And then here we are okay, so here we have aorta. We're seeing that right renal artery going into the kidney, this big C-shaped guy's kidney. And then here's our IBC, and anterior to the aorta is that left renal vein. So the only thing posterior to the IBC. Unless you have some kind of nasty weird information like anything. Here we are with color Doppler on. So in this case, you'll learn this in physics. Red means it's going towards our transducer. Blue means it's going away. So in this case, we have, you don't know about aliasing yet, but this is our red going in and our blue going out. Make sense? Okay, here's an IBC. So we've got liver here, right atrium up here. So this is the superior portion, inferior portion, anterior, posterior. And look at this little teeny tiny guy posterior to the IBC in cross section. So he is coming to attach to this kidney. And then if we followed him the opposite way towards the bathroom, then we would hit the aorta. This one has two. Amazing. 2 for 1. But they're the only vessels that run posterior to IBC. Okay, no one cares about this. We don't usually see them. I'm not going to ask you about them. Not going to ask you about it. Oh, iliacs, yeah. So bifurcation of the forelumbar for the arteries. And then they further bifurcate. You guys probably remember this from anatomy. And so you get the split right at the lumbar section, and then these like further split into an internal and an external. And then when we do pelvic stuff, we'll talk more about that. Okay, IBC. right and left iliac veins are going to confluence together, usually around the umbilicus. We don't usually see gonadal. This is okay. Back. Sorry, I'm distracted. No. We don't usually see gonadal arteries, but it's an important thing to know that. So here's our IVC. Here's our kidney over here. So here's, testicles. Oh, that is. Oh, okay, I want that. So the gonadal artery comes up and actually plugs into the left side, whereas the right one actually plugs into the IVC itself. So they have two different ways that they anastomose onto the IVC. And this becomes a big deal because, say we had that Nutcracker Syndrome, and it's compressed, and we aren't able to get the venous flow back from that kidney, we're also not able to get the venous flow back from the testicles or the ovaries. So that Nutcracker Syndrome can have a kind of overall bigger problems than just kidneys. Oh, and hepatic veins. So hepatic veins are in the liver. There's 3 of them. There's a middle, left, and right, and they actually drain the blood from the liver back into the IVC, and right at the proximal portion of the IVC where it goes into the right atrium. And we'll learn more about those too, because that'll be part of the things that we scan during liver evaluations. We'll scan those. We'll take images of them. Okay, we don't care. We care. We care. We care. All right. So they didn't do very good job of this one. But anyway, so bifurcation comes together. And this is probably old hat for you guys. I mean, this is not news, right? Okay, good. I got a head nod. Okay, great. Okay, so here it is in ultrasound. So we've got this IVC. It's anechoic. Why is it anechoic?
There's blood, it's fluid.
And it's fluid. Yep, you got it. And then here's the hepatic vein going in there, and then here's the right atrium of the heart. And you'll notice, remember how it will kind of preserve, that beam will get preserved. So see how bright it looks? It's because it's not reflecting anything back, so it has what we call enhancement. So it's kind of enhancing the area posterior to the IVC. Oh, here we are on MRI, yes, MRI. Okay, iliac, I know we're going to ask you this. Good to know for your clinical stuff, not a Shea question. Not a Shea question. Good to know, just not a Shea question. This one, we do need to know about renal veins, and we'll talk more about these when we scan them. We don't oftentimes see them, but like remember that gonadal plugs into that left side, so you just want to make sure that we're aware of the anatomy of the neighborhood. But I'm not going to ask you specific questions about this stuff. I may have you like draw a picture of your homework or something. I'm going to be like, tell me the 15 things that come off the aorta. Okay, hepatic veins. So they're very close to the right atrium, drains the liver back to the heart. And when we get into liver, it's going to be one of the things that we assess, and so we'll talk about it a little bit more when we talk about liver and hepatocellular pathologies. And there it is. So transverse. So here's our IVC and transverse. We've got anterior, posterior, right side, left side, and here's our hepatic. Now hepatics don't typically have bright walls, but this one does because it's really flat to our machine. It's flat to our beam. But more often you're going to see that they just have the anechoic walls, and it's the portal veins that have bright walls. More on that later. Hold on to your little heads. All right, here's a hepatic, middle hepatic. So our IVC is here, right atrium, so superior, inferior, anterior, posterior, and here's our hepatic vein going right into the IVC, getting ready to go into that right atrium. And this is a coronal iliac arteries. Okay, so I get to do this every year. If you can give me this image in lab sometime between now and the end of the quarter, I will give you 5 points of extra. It's a tricky one. But you don't try this week. I mean, you're gonna be like, oh. But yeah, if you can reproduce this image by the end of the quarter, I'll give you 5 extra credit points. Okay, so where was that left renal vein in relation to the AO? Remember? Tommy's arm. Left renal vein. No. So the left renal vein is anterior to the aorta. So where is the left renal vein in relation to the SMA? shout it out. What do you got? There's no wrong answer, you can screw it up. It's your birthday.
Posterior.
Posterior, yep, you got it, posterior. And then where is the right renal artery in relation to the IVC?
Right.
Because the only guy who lives here on the IVC.
Posterior.
Posterior, you got it. And then where's the SMA in relation to the AO?
Anterior.
Well, it kind of hangs off. It's like an elephant trunk off of it. So it's like, it was like this, right? So I'm the aorta, and here's my SMA. So, what do we think?
Anterior.
Anterior. You got it. Nice work. You got it. Okay, that's it, folks. How's it going? Lot to take in?
Uh-huh.
Yeah. So that's all I got for